Welcome to Provider Workup of Positive Findings in CT Lung Screening. My name is Merlene Tucker, and I'm running this Dialogue for Health web forum with my colleague, Tanya Hammond. Thank you to our partners for today's event, the Lung Cancer National Training Network at the University of Louisville and the Bristol Myers Squibb Foundation. And now, I'd like to introduce Celeste Worth, the moderator of this event. Celeste Worth has over 20 years of experience in cancer control and provider education and is the director of the LUCA National Training Network at the University of Louisville. She is also a tobacco treatment specialist and master certified health education specialist. She was previously a co-investigator for the provider education component of the KY Leads Collaborative and the professional education and training manager for the Kentucky Cancer Program at the University of Louisville. And I'd like to say, welcome to Celeste.
Thank you so much, Merlene. Hello, and welcome to the fourth webinar in the LUCA National Training Network series. We appreciate you taking the time to join us today for what promises to be a very informative and eye-opening look at some of the latest data related to lung cancer screening and management of positive findings. As we begin, I want to share how LUCA National Training Network at the University of Louisville can be a free resource for you. The LUCA National Training Network, which also goes by LUCA, is funded by a grant from the Bristol Myers Squibb Foundation. In addition to providing education and training directly to providers and other health professionals with webinars like this, and an online course you'll get access information for later, we also provide assistance, materials, and other resources for those who are educating health professionals on topics related to care for those at risk for lung cancer or who have been diagnosed. Our website at lucatraining.org recently received a national award and has over 300 tools and resources for both providers and patients. We encourage you to check it out, and please contact us at the email on this slide. We also want to make sure that you're aware of the various resources that are available, so you can go with any questions or requests to lucatraining@louisville.edu. To get important updates and announcements about new offerings, tools, and other resources, we invite you to follow us on Facebook and Twitter. And for the first time today, we are conducting live tweeting during today's webinars. So please feel free to follow us on Twitter and add comments with hashtag LUCAWebinar. And make sure you have the capital L and capital C, capital W for webinar. I'm very pleased to and privileged to be able to have this person participate with our webinar today. Dr. Andrea McKee is a senior partner at Radiation Oncology Associates, PA, former chief of the Division of Radiation Oncology at the Leahy Hospital and Medical Center, Sophia Gordon Cancer Center in Burlington and Peabody, Massachusetts, and current president of the Rescue Lung, Rescue Life Society, an independent 501c3 organization established to eliminate barriers to CT lung screening adoption through public and provider education, advocacy, research, and development of novel tools which streamline high-quality program implementation and management. Dr. McKee is actively involved in CT lung screening advancement on a local and national level as a member of the National Lung Cancer Roundtable, several New England-based patient advisory councils, as a member of the Massachusetts State Cancer Control Steering Committee, co-chair of the State Lung Cancer Subgroup, and as advisory board member to the Lung Cancer Alliance and the American Lung Association. Dr. McKee, welcome, and I'll turn the mic over to you.
Thank you, Celeste. Good afternoon, and thank you, everyone, for joining us today for a discussion of positive findings in CT lung screening. You saw my disclosures. Lung cancer screening with low-dose CT improves outcomes in high-risk individuals with a 20% relative risk reduction in mortality seen in the NLST and a 24% risk reduction in men and 48% risk reduction in women, published in the European CT screening Nelson trial. Concern over false positives, however, and iatrogenic harm continue to limit lung cancer screening implementation. As well, they present a challenge for providers to conduct accurate shared decision-making encounters, a requirement for reimbursement by CMS. Possible positive finding categories on a lung screening exam include those in the lungs specifically, which can be a true positive in people who actually have lung cancer, or a false positive in those who have a lung finding that turns out not to be lung cancer. Of note, this definition also excludes other types of cancer spread to the lung or serious lung infection, and thus false positives can be of significant clinical relevance to the patient, which we'll touch upon later today. I will be discussing workup of positive lung findings, and my colleague, Dr. Shawn Regis, our program navigator, will be discussing the other category of positive findings, those outside of the lung fields. These include incidental and significant incidental findings. Shawn will also speak to the importance of tracking or navigating positive findings in CT lung screening. Let's start with what defines a positive in the NLST. As a reminder, in the NLST, patients were randomized to low-dose CT versus chest X-ray. Baseline prevalence scans were performed, followed by 2 additional screens, so 3 scans over 2 years. A positive test was defined as a non-calcified nodule greater than 4 millimeters in diameter or other findings suspicious for lung cancer, like adenopathy or effusion. Workup was determined by the patient's primary care physician, not the NLST investigators. However, the NLST reading radiologist's recommendations were available. It is very important to note that this is no longer how a positive exam is defined today. LungRads uses a 6 millimeter threshold for non-calcified solid nodule, and in the Nelson study, 2 serial CT scans over a predetermined time period were used before assigning a positive or negative value to an exam, with the exam being coded as indeterminate during that wait time. Nelson therefore reports an exceptionally low false positive rate of 2% using their definition. Not surprisingly, low-dose CT is more sensitive, approximately 3 times more sensitive than chest X-ray. On the first 2 screens, there's a 27% chance for a lung finding. After that, the rate decreases to 16.8%. Any solid nodule that has been stable for 2 years is considered benign according to the NLST and Fleischner guidelines. Now, of course, we use LungRads in these situations. The risk for finding a significant incidental is 7.5%. Dr. Regis will cover incidentals later in the talk today. False positives were handled non-invasively for the most part. If we compare to mammography, something we're all familiar with, the discovery rate, or the chance that you will get a call back for additional imaging, is 20 to 25% for low-dose CT and about 8 to 10% for mammography. With low-dose CT, the callback occurs in 3 to 6 months. With mammography, the patient is immediately called back. The false discovery rate, meaning the chance that you don't have cancer if you get called back, is 96% for both low-dose CT in the NLST and mammography. The false discovery rate of 96% seen in the NLST has been misstated by numerous medical experts in the field of CT lung screening to be the false positive rate. The Rescue Lung Rescue Life Society has been working hard to get the medical literature corrected on this point, as we suspect that understanding the correct false positive rate is very important to provider and patient engagement in CT lung screening. The false positive biopsy rate, meaning the chance that you have a biopsy when you do not have cancer, is 0.4 to 2.4% for low-dose CT and 1.4% for mammography. False positives were handled non-invasively for the most part with chest X-ray, CT, or PET-CT for follow-up in the NLST. Invasive diagnostic procedures on patients who didn't have cancer were rare at about 2.4%. The complication rate for patients who didn't have cancer was also rare at 1.4%. The major complication rate for those without cancer was very rare at 0.06%. For patients who have cancer, these are the true positives, the risk for major complication was 11.2%, and the surgical resection mortality was 1%. But remember, these patients actually have lung cancer, the deadliest cancer that we see in the United States. In the NLST, with the 4 millimeter non-calcified solid nodule threshold, the false positive rate was 26.3% at baseline and 59% at T2, for an overall false positive rate of 23.3%, as you see here. When investigators applied the 6 millimeter lung RADS non-calcified solid nodule threshold to the NLST data set, a 12.6% at baseline and a 5% at T2 false positive rate was seen, for an overall rate of 7.8%. In clinical practice at our institution, we published our false positive rate on several thousand high-risk individuals using the lung RADS system originated at Leahy, with a baseline false positive rate of 10.6% and 5% at T2, for an overall rate of 7.6%. One of the questions that was submitted prior to this meeting was whether or not COVID-19 has had an impact on false positive rates. Early on, we instituted a policy to contact patients immediately before their scheduled exam to ensure they remained symptom-free and without recent upper respiratory infection, after learning during the first year of our program that false positive rates had increased during the flu season without such a policy. Since instituting this new policy using this approach, we have not seen an increase in false positive rates relative to COVID-19 after now having screened over 700 individuals in the post-COVID surge environment. It's important to recognize the false positive rate over time goes down in a mature CT lung screening program. This is a busy slide, so allow me to walk you through it. Baseline scans are the dark red, interval scans are the pink, and incidence scans are the salmon color. In year one, when we started the program, we see only baseline and interval scans as patients have just entered the program. Over time, there are many more incidence scans seen in the larger salmon color bar by year 2018, as a higher portion of patients have been enrolled in the program for many years. Similarly, the dark blue represents cancers diagnosed at time of baseline scan. At year one, all diagnosed cases were done off baseline scans, but over time, the majority of lung cancers diagnosed are done so off non-baseline studies. This is seen in the light blue by year 2018, where 27 of the cases diagnosed were in the non-baseline studies. And in a mature program, we are more often picking up new cancer that develops between annual screens, and these cancers are typically very small. Our current program rate of diagnosing stage 1 lung cancer in these later rounds of screening is now 90%. So 90% of the time, we're finding these new, very small cancers that are arising between years of screening. Similarly, in a very mature program, once you've really reached your steady state, approximately 90% of the patients are going to be in that annual screening rounds, with only 10% entering and leaving the program at any given time. Here is one of the published false positive corrections brought out through the work of the Rescue Lung, Rescue Life Society. Without such published corrections, we were continuing to see new publications requoting the wrong 96% false positive rate, which, as stated in this JAMA correction here, is actually the definition of the false discovery rate. So hopefully we will stop hearing that information moving forward. So we decided to look at what happens to positive suspicious findings in our large clinical lung cancer screening program. As of April of 2020, we had performed almost 20,000 lung cancer screening studies in 7,521 high-risk individuals. We retrospectively reviewed all Leahy lung cancer screening charts from January of 2012 through June of 2017 on 4,490 patients who had complete follow-up available through January of 2019. Why did we stop in June of 2017? This graph demonstrates what happens to individuals with suspicious findings or lung rads 4A, 4B, or 4X findings over time. Time point 0 is the suspicious finding, after which one of two things can happen. The patient can be found to have lung cancer, or the finding is determined to be benign, in which case these cases are most often rendered a lung rads 2. The graphs above the central days timeline represent those who are found to have lung cancer after a lung rads 4A finding in blue, a 4B finding in red, a 4X finding in green, and the purple represents all lung rads 4 cases later found to have lung cancer. So these are above the days timeline that you're seeing in the center of this graph. If you go to the below graph, these are patients who are eventually not found to have cancer and become a lung rads 2. We're using the same color coding for the different categories of suspicious findings. So blue is a 4A, red a 4B, green a 4X, purple represents all the 4s. Note that by 360 days, if you look over to the right side, about 92% of patients found to have cancer have been diagnosed with the disease. And at 360 days, 75% of benign cases have been determined to be benign. So if you look out only 1 year, you'd be missing about 8% of lung cancers in this analysis. And looking at the graphs, waiting a full 18 months to run such statistics in your program allows you to analyze both the positive and false positive cases, which have essentially come to resolution by that time point. I'd also like to point out in the green box that is above the midpoint of the graph, you see the suspicious predictive value at 365 days. For a lung rads 4A case, the suspicious predictive value is 26%. One of the questions that we received from the audience is, can a 4A case wait for the next year to undergo an incident scan to avoid a copay as a diagnostic follow-up scan? I see two potential problems with this. First and most important is that at 90 days, 50% of the lung rads 4A cases with cancer have had their cancer diagnosed. You can see that on the green above the bar graph. And as you see, additionally, on this slide, the suspicious predictive value is nearly 30%, meaning that nearly 30% of these lung rads 4A cases actually have lung cancer. So I wouldn't want to wait out a full year because of that copay issue, just from a clinical standpoint in patients with a 30% chance of actually having lung cancer. The second issue, at least in our program, is that once we have a 4A finding, the next exam would still be a diagnostic study subject to copay until that actually becomes resolved to a lung rads 2. Other programs may not handle their coding in that sort of a situation. As long as they are waiting 11 months from the lung rads 4A study, they may be putting that next exam in as a screening incident scan, but that's not the way we handle it in our program. We follow NCCN guidelines and screen both NCCN Group 1 and 2. Patients with suspicious findings or lung rads 4 cases were evaluated for interventions and outcomes. The table shown here describes the characteristics of lung rads 4 patients with fairly equal male and female numbers, median age of 65 and a PAC years of 43, with slightly over half the lung rads 4 cases currently smoking. 80% of lung rads 4 cases are in NCCN Group 1 and 20% are in NCCN Group 2. NCCN Group 2 is a second high-risk population who have not previously enjoyed an insurance mandate for screening coverage, although it appears this will be changing soon as the USPSTF has released their updated draft CT lung screening recommendation to lower the threshold age for screening entry to 50 from 55 and PAC years from 30 to 20 PAC years on the basis of the Nelson trial and more recent randomized data. We hope to see the finalized USPSTF recommendation in place before the end of the year. Of the 4,490 cases, 3,280 had complete follow-up at Leahy. Of those, 345 were found to fall in the lung-RADS4 category, with 311 having complete follow-up at Leahy. Of the 311 lung-RADS4 patients, 86 underwent one or more invasive diagnostic procedure, 13 were treated with SBRT, 51 underwent lung resection, and 161 were managed with continued screening. Among the 86 patients undergoing one or more invasive diagnostic procedure, 42 had lung cancer. There were 4 non-lung cancers, including metastatic breast, metastatic renal cell carcinoma, large B-cell lymphoma, and follicular lymphoma. Remember, these findings here are characterized as false positives because they weren't lung cancer in the lung. They were cancer in the lung, but from another primary. There were 5 benign findings, and there were 35 non-diagnostic cases. This yielded a 41% non-diagnostic rate, which is actually slightly higher than what we tend to see in the non-screened population. We suspect this is probably because the lesions in the screening population are smaller, and for the fact that we have slightly more mixed solid / part solid lesions seen in the screening population. 5.8% had truly benign disease. This included necrotizing granuloma, organizing pneumonia, and hamartoma. And nearly 50% had lung cancer treated with surgery, chemoradiotherapy, or SBRT. 2 patients died of other causes before treatment, not related to their lung cancer. Looking at diagnostic interventions, PET-CT was obtained in 60% of lung-RADS4 cases. There was a question from the audience about the use of PET prior to interventional biopsy. Our response would be that most our pulmonologists like to have a PET prior to an interventional procedure. However, it is not always covered by insurance, and they make the comment that it is not always going to change what they're going to do, as they will be staging the nodes in either case with EBIS. Bronchoscopic biopsies were done in 17% of lung-RADS4 cases. CT-guided biopsy were done in 10% of lung-RADS4 cases. And then the rarer procedures, such as mediastinoscopy and thoracentesis, are listed in the table. There have been no periprocedural deaths or major complications, and the rate of diagnostic interventions for those with non-malignant disease for the entire lung screening population is 0.95%. In this table of therapeutic interventions, it's shown that path-proven cancer is in place only 20% of the time prior to surgery, with 80% of those taken to surgery having presumed lung cancer after multidisciplinary review. SBRT was used in 8% of lung-RADS4 cases, with path-proven disease slightly higher in this group than those going to surgery at 24%. Palliative chemotherapy rarely used at a rate of 1.9%, and definitive chemoradiotherapy in 4.5% of lung-RADS4 cases. In those undergoing lung resection, near 50% underwent a lobectomy, and 50% underwent a wedge resection or segmentectomy. There were no pneumonectomies. And 90% received thoracoscopic resection, with less than 10% undergoing thoracotomy. Benign disease was seen in 14 cases, or 16.9% of surgeries, comparing favorably to the rate that was published in the NLST of 24%. Overall, 0.43% of Leahy lung cancer screening patients screened underwent surgery for benign disease. There were no deaths within 60 days of surgery. 6% had a major complication according to NLST criteria, comparing favorably to that of the NLST of 11.9%. The most common complication seen was atrial fibrillation, which was managed with pharmacologic intervention. 5 patients experienced a prolonged air leak, and 5 patients experienced pneumothoraces after operative chest tube removal requiring chest tube replacement. 25 patients underwent SBRT, 24% of whom had path-proven disease. 76% had presumed lung cancer based on department policy of multidisciplinary team review, patients being evaluated by IR and pulmonary for biopsy risk, patients known to be at high risk for lung cancer, PET staging, and serial growth of the lesion over serial scans. There were 8 recurrences following SBRT. All but 1 were distant, with half of the recurrences seen in patients with initial path-proven disease and half seen in those who were presumed to have lung cancer, and later the biopsy of the distant site proved their lung cancer diagnosis. So looking back at our initial NLST positive finding slide and comparing to what has been seen in clinical practice, we see a 7.8% false positive rate, less than the NLST rate of 20 to 25%, and a favorable rate of intervention on benign disease of 0.4 to 0.95% in our program, comparing to 0.4 to 2.4% in the NLST. We feel these numbers all compare favorably to what is seen in mammography. Complication rates compare favorably. Having a shared decision-making conversation with patients has been challenged by the various reports on statistics surrounding CT lung screening. The numbers listed here are all published false positive rates in the literature. Being precise with the definition of positive based on the reporting structure used and the year of screening, baseline versus incidence, helps shed some light on the discrepancies. However, in the U.S., where lung RADS is often used, it is accurate to say the false positive rate in screening is less than 10%. Similarly, published overdiagnosis statistics are listed here with anywhere from 3 to 70%. Updated 11-year NLST data has ended this debate for the most part with published overdiagnosis rate of 3%. Structured reporting with algorithmic follow-up recommendations and multidisciplinary team to evaluate suspicious finding has yielded rates of less than 1% likelihood of surgery or intervention on benign disease. So the answer for our question was less than 10% and less than 1%. And I think that was number C. I just put in an example of a quick shared decision-making conversation that can help in the clinics. With the patient, you're at high risk for lung cancer. Essentially 2% at baseline is a good rule of thumb, although there are calculators out there that you can use to get more precise with your patients. New screening guidelines recommend annual CT lung screening for someone like you. We find early stage lung cancer about 85% of the time. Screen detected stage 1 lung cancer is 90% curable with surgery. There's a less than 10% chance a nodule is found that's not cancer. It's managed mainly with imaging follow-up. Surgery for benign disease is rare at 0.43%, and invasive diagnostic intervention is rare at 0.95%. If imaging follow-up is recommended and cancer ultimately found, it would be early stage. There's no copay for annual screening exam. Radiation exposure is that of a mammogram. Smoking cessation for current smokers as per usual practice. And there is a small possibility we find something other than lung cancer requiring care escalation. Dr. Regis is now going to cover that issue in detail.
Okay, thank you so much, Dr. McKee, for an excellent presentation. It's very interesting and compelling to hear statistics from such a mature lung screening program that I think really helps a lot of other programs that aren't quite as far along know some of what to expect and have more up-to-date information to share with their patients and with others in their health system. So at this point, I can start our introduction for our next speaker that we're also very privileged to have share with some additional information tied into what Dr. McKee was describing at the beginning, and give another key aspect to all of these considerations. Dr. Shawn Regis is a patient navigator and associate research scientist at Leahy Hospital and Medical Center. clinical assistant professor at Tufts University, and current secretary of the Rescue Lung Rescue Life Society. Dr. Regis manages a CT lung screening database with data on over 8,000 patients and greater than 19,000 scans, and is on the Massachusetts Comprehensive Cancer Prevention and Control Network's Secondary Prevention Subcommittee focused on lung screening, and was a member of the advisory committee for an Association of Community Cancer Centers initiative to develop an optimal care coordination model for lung cancer patients with Medicaid. Dr. Regis has been invited to speak about various lung cancer screening topics at numerous sites and conferences across the country, and we are fortunate to have him with us today. Dr. Regis, welcome, and I'll turn it over to you.
Thank you so much, Celeste, and everyone at the LUCA Network for having me here today. And thank you to everybody who's coming out to participate in the webinar as well. I'll be talking first about radiologist recommendations for incidental findings. And as Celeste mentioned, those poll results with the majority of people not being sure of what their rate is in their program, not entirely surprising, and that'll be part of the focus of my talk today. There are major discrepancies in the reporting of incidental and significant incidental findings in CT lung screening, and it's because there's not really a great consensus on what the standard definition of that would be. As Dr. McKee mentioned, a lot of times it's very easy to compare lung screening with mammography, but this is one of those instances where it's quite different. In breast cancer screening, you're doing an image of the breast. In lung cancer screening, you're scanning the lungs, but you're getting a whole bunch of other things as well that can't be ignored, and so they have to be commented on in the report. The question is, what of those are significant findings versus just incidental findings that can be mentioned but don't need any immediate action? Most of the sites in the US are using LungRads to do their screening, which just kind of has this S modifier for any significant incidental finding. It's kind of left up to a radiologist, and it basically just says that it's a clinically significant or potentially significant non-lung cancer finding, and the management would be appropriate to that specific finding. They do give an estimated prevalence of about 10%, but again, at this point, there's no real extension on what exactly those significant incidental findings are. In the NLST, the kind of general idea behind the finding was similar to what we see in LungRads, where it's an abnormality that is not related to lung cancer, but it's up to the radiologist to determine whether that's clinically significant. And we saw in the baseline round of screening in the NLST, it was about 10%, and then in the annual screening rounds, it did drop off a bit down to closer to 6%. There was a study in JAMA Internal Medicine with the VA population that noted a significant incidental finding rate of 41%. And this was quoted a lot in the literature. And you can see that in the range, it goes anywhere from 20% up to 63% in this study. And again, that's because there's no real standard definition here. The radiologists and the coordinators were basically left to decide what they felt was an incidental finding that would likely require some sort of follow-up or further evaluation. And because of that lack of specific guidance, that's where we start getting this wide range of numbers for significant incidental findings. In our program, we have a very specific definition for a significant incidental finding. It is an unexpected finding, which is either new or unknown, and requires some form of clinical or imaging investigation before the next recommended CT lung screening exam. And there are two big parts of that. The first part is the unexpected part, which I'll get to in a moment. And the second part is the new and unknown part. You'll see that at baseline, a little over 6% of our scans have a significant incidental finding. And then that drops down dramatically in the annual screening rounds to closer to 2 to 3%. And the reason for that is because we have this new or unknown part of our definition, where on a baseline screening exam, if there's, say, a lesion on a kidney that is seen, it's noted as a significant incidental finding. There's a recommendation given to follow up on it. But if that patient comes back on their annual screening round and that lesion is still there and not changed, then it's not considered new anymore and it was previously known, and so it's not recorded as a significant incidental finding. It'll still be noted on the report, but it's no longer considered a significant incidental finding because it was previously known. So the differences in the general or lack of a definition of a general significant incidental finding is an issue, and even within the specific definitions that do exist, there's discrepancy as well. So in the VA study that I mentioned before, that's that E table in the top left, Half of their significant incidental findings came from things like coronary artery calcifications and emphysema. And lung rads as well, if you look at this piece that's taken from the data entry form, lists coronary artery calcification as a significant incidental finding as well, though they do specify that in their case it would be moderate or severe that would make it significant. We took a look at the patients in our program. We do comment on coronary calcifications and emphysema on every single scan that we do. It is listed as an incidental and not a significant incidental, and that kind of gets back to the unexpected part of that definition that we have. Almost 90% of the patients in our program have some level of either coronary calcifications or emphysema. These are patients who have smoked over 200,000 cigarettes in their lifetime, so we expect to see these kinds of things in these scans. We do report it on every single scan, but like I said, it's reported as an incidental rather than a significant incidental. Our coronary calcifications break down roughly 25% in each group between none, mild, moderate, and marked. So even using the ACR definition and saying that it's just moderate or severe calcifications would still give us about 50% of our patients having a significant incidental finding due just to coronary calcifications. And about a quarter of our patients have either marks, coronary calcifications, or emphysema, or both. So even that definition of a severe calcification or emphysema finding would still give us about 25% significant incidental findings just based off of those things. Another area of discrepancy would be in the infectious or inflammatory findings. ACR lung rads implies that these findings would be labeled as a lung rad 4X and not treated as a significant incidental finding. The VA study did treat them as a significant incidental finding, and the rate was about 25% of those significant findings were infectious or inflammatory in nature. So if we take those findings and the coronary calcium and emphysema findings, that's about 75% of those significant incidental findings that were reported in the VA study, which explains why that number was all the way up at 41%. In our program, we have a way of kind of separately characterizing these scans as infectious or inflammatory in nature. And consistently across the board, whether it's baseline or annual screening, we see a rate of about 7% of our scans come back with this finding. So again, if those are going to be included as a significant incidental finding, you're going to see a good amount of them, and it's going to be a little bit higher than, say, what was seen in the NLST or what we've reported in our program. So it is unfortunate that there is no standard definition for what a significant incidental finding is, or no general guidance really provided. So it's important for the individual program to then make up an agreed upon definition for their program and have recommendations as well. This should be determined by the program management, the steering committee, something like that, where you're deciding ahead of time, this is what our significant incidental findings will be. Here's what we're going to recommend for those significant incidental findings. And you should consider things like coronary calcifications, emphysema, infection and inflammation, and then what we would consider to be kind of the more straightforward significant incidental findings like masses in other organs, aortic aneurysms, things like that. You just need to keep in mind when you're setting these definitions that depending upon what you do and do not include as significant, that's going to change the percentages of your results as well. So if you're including, all coronary calcifications, and then it's not going to be overly helpful to compare your results to the NLST results because it doesn't appear that they did that based on the low number of their findings. So one of the things that we did when we presented this data at the World Conference on Lung Cancer in 2018 is we compared our program with the Cosmos study, which was an Italian lung screening study, which had a very similar definition of a significant incidental finding for what we use at Leahy, and a duration that was the same as what we had for our patients. And what we found was that less than 5% of the overall scans and less than 10% of patients reported a significant incidental finding over those 5 years. But 6.2%, we had the cancer detection rate for these significant incidental findings. So these aren't nothing. These are other cancers that we're finding in other parts of the body that are still important to the patient and still saving lives by finding them. For every 7 or 7.5 lung cancers that are found, we're finding one of these significant incidental cancers. And unfortunately, a lot of talk, especially when this VA study came out, there was a lot of talk about how these significant incidental findings were a risk and a harm of lung screening, and all these people are coming back in for no reason. And it should be viewed as a benefit. Like I've said, depending upon how you're going to define your significant incidentals, they're really much lower than what we've seen in some of the literature. and you're saving lives even more so than just finding lung cancer. So that's how I think we should be looking at these significant incidental findings rather than saying that they're an additional harm for the patients, because that isn't really the case. So the next I'll talk about is the importance of bringing the patients back in. We've already talked a little bit about how we know lung cancer screening saves lives now in a variety of ways, but it only really does that if we can get the patients to come back for the recommended follow-ups that are given. So how do we best do that? The main point here is that we can't really rely on the healthcare providers to do it all. They don't have enough time to do it with everything else that's already on their plate. If we take an example, primary care physician who's got about 2,500 patients, about 75 of those are going to qualify for lung screening, which means the PCP is explaining what lung cancer screening is. They're confirming the patient's eligibility, talking about risks and benefits, talking about smoking cessation and abstinence. They have to write the order for the patient. And then of those patients, the vast majority are going to be a negative scan, in which case the PCP is going to have to write a new order for 12 months from then, determine if the patient is still eligible. For those patients who had a positive scan, it's the same thing, but in a shorter time period, usually around 6 months, they're writing a new order for that patient. There will be some suspicious findings where the primary care typically has to let the patient know what those findings were and refer the patient to a specialist for further evaluation. And then, as we just talked about, there are going to be a varied level of significant incidental findings depending upon how they're defined by the institution. And that's a lot to try to put on a healthcare provider to remember for every one of their lung screening eligible patients, on top of what they have to remember for the other patients that are not in lung screening in their panel. So the healthcare providers are really the ones that get the patients into the program, but it's up to the navigators and a program management system to keep the patients in. The first big step goes back to the shared decision-making conversation that Dr. McKee mentioned, where the healthcare provider does need to inform them up front that this is an annual process. It's not a one-time scan to see if you have lung cancer and then you're done. If they can lay the groundwork during that shared decision-making visit and let them know that it's an annual thing, it makes things a lot easier down the road as well. But the heavy lifting needs to be done by the navigator and the program management system. So the main two ways that we do that at Leahy, we send results letters to the patients. For a negative scan that basically just says, we don't see any signs of active lung cancer, we'd recommend you come back in about a year. And for positive findings, it's that there were some nodules that are likely benign, but we'd like you to come back in 6 months to make sure that that's the case. And in both cases, we give a specific date, and that just kind of puts it in the patient's mind already that they're expected to have a lung screening exam on that date in the future. We can then start working with the ordering physician to get that new order, give the patient a call, and get them scanned. If they don't make an appointment, or if they miss an appointment that they've had scheduled, 30 days after that date, we'll send them a reminder letter that lets them know we expected them in on a certain date, and if they could give us a call to get set up, that would be great. 60 days afterwards, if we still haven't heard from them, we send them that same letter again, but we also send a version to the ordering physician, try to get them on board with getting the patient back into the program as well. And then 90 days after, we'll send the same letters to the patient and ordering physician with the added caveat that the patient is effectively discharged from the program, which really just means we're not going to be sending them the letters anymore. They're always welcome to give us a call and get back into screening, which hopefully the primary care is talking to them about every year anyway. And in our program, we see about 86% of our patients coming back and following up with these recommendations from the radiologist. And a large part of that is because we have the program management software that can keep track of these things, and we're sending reminder letters to patients and making sure that they're getting in for their scans. I would be very surprised if you could get a number that was even close to this if you were just relying on healthcare providers themselves to try to remember all this information and manage all these patients on their own. Dr. McKee showed this slide a little bit earlier, so I won't spend a lot of time on it. I just want to point out that, as she mentioned, as your program begins to mature, you see a lot more annual scans than you do baseline scans. And this is kind of the why we need to bring patients back in. We talked about the how, and the why is because as you bring them back in, as they get back into annual screening, that's where you see the real, even increased mortality benefit. On baseline screening, our early stage lung cancers are a little under 80%. Once you get into annual screening, it's a little under 90%. And that's because during baseline, you still have some patients who are weeks or months away from maybe being symptomatic, and so there's still some bulky disease there. But on the annual screening, you're really catching those real small cancers, and that's where the great benefit really is. And we saw this in the randomized controlled trials as well. The NLST showed a benefit, but we actually saw a greater benefit in the Nelson and Mild studies because they screened for longer and they did a follow-up at a longer period of time. And so if we can keep those patients in screening, they're going to get the more benefit than if they just do a one-time scan. And lastly, if you have a way to track all these patients, a system that'll do that for you, you can provide feedback to your referring physicians. You can let them know how many patients quit smoking, how many of their patients were diagnosed with lung cancer, what stage that lung cancer was. You can tell them how many patients never came in for a scan or who came in for a scan but then never came back so that they can talk to those patients. And you're basically telling them what happens to all their patients that they refer into the program. And it's such a success story that they're just going to keep referring more patients in. And so if you have those tools in place, you can help them out. You'll get more patients in. You'll be saving more lives. And I think that's what we're all trying to do here. So I thank you again for the time, and I'll turn it back over.
Thank you so much, Dr. Regis, for a terrific presentation. What you all had together was extremely beneficial. While attendees have a chance to submit a few questions for our speakers, I will quickly share information about a couple of key offerings from LUCA. In two previous webinars, Dr. Katie Garfield at Harvard Center for Health Law and Policy Innovation introduced and reviewed two new resources developed in partnership with LUCA, which address coverage for lung cancer screening and tobacco cessation coverage. Those publications and the recorded webinars are available on our website at lucatraining.org. There you can also find the recording of our last webinar on June 24th by Dr. Joelle Fatih on the power of telehealth in primary care, pragmatic adoption and integration across the care continuum, with examples of the benefits of telehealth use with lung cancer screening and tobacco cessation. I'd especially like to share information quickly about our free award-winning comprehensive online course, Lung Cancer and the Primary Care Provider. This video-based course covers lung cancer care across the continuum in 3 separate modules. It provides free CME, nurse practitioner specific credit, or AAFP prescribed credit, and is available to anyone. So you can access this on our website at lucatraining.org/course. And now, as I switch things over, we will allow Drs. McKee and Regis to answer questions which have been submitted in our remaining time. I'm going to start with the questions that were sent in when participants registered for this webinar and move to those submitted during the webinar as time allows. So Dr. Regis, what systems are available to alert primary care providers to order annual low-dose CT for those patients who qualify? At our health system, this person writes, a BPA fires an epic alerting the PCP to screen, but what about subsequent years? Anyone with a plan for this?
Yeah, that's a great question, and EHR is a really great way to help our healthcare providers, know when there are patients that are eligible and when they're due to come back for screening. Setting up a BPA like that is fairly straightforward to do if you can make sure that you have all the correct information in there, the PAC year history, and if and when the patient quit smoking. The thing that we add in that makes it a little bit different and applies to annual screening as well as baseline is we just kind of add in that they can't have had any kind of chest imaging within the past year. So now you're not necessarily looking for if they've ever had a screening exam. You just want to know, do they meet screening guidelines and have they had a CT in the past year? If not, then the BPA will fire, and then it doesn't matter what round of screening they're on. We just know that we have to get them in to get their chest CT, preferably part of the screening program if they're not already being followed.
Great. Okay, well, the next one I have is for Dr. McKee. How would you help patients understand the importance of keeping their annual appointments?
So I do think that Shawn and I both kind of touched on this. The key really is in that shared decision-making conversation where you're presenting their risk of having lung cancer at baseline, and then also reinforcing that, due to their risk factors, their body is essentially making lung cancer at a rate of about 1% per year. That's what we're seeing, is that these new lung cancers later, once the patient has been in their annual screening rounds, are developing lung cancer at a rate of about 1%. So when they hear that, I actually, because I do a lot of referring patients myself into our program, I can see their face kind of like, wow, geez, that's what's happening in my body. And I think that reinforces that, that's when we can catch it early, when between scans, a new lung cancer develops. It doesn't have enough time to to really get going, and that kind of clicks in their head. I tend to use a lot of parallels to mammography for particularly my female patients, but even men understand, the paradigm behind annual breast screening. So drawing parallels to things that they can relate to really helps, allowing them to ensure that staying in the program as long as they qualify will give us the best shot at finding that early stage curable lung cancer is how we can get them to kind of come back. And then, the tracking system is obviously critical. And so if you don't have a tracking system, a navigator who's tracking these findings and supporting you in this endeavor, it's a shame. I know Shawn uses the comparison, how do you ask a surgeon to go to the OR without a scalpel? You need tools to kind of to really do this in the way that we want to get it done. But there are some examples I've heard where providers may actually keep track of these patients, their own patients themselves. As Shawn presented, it's typically going to be about 75 patients in a primary care panel who are going to qualify for lung screening, and whether or not, you can kind of try to keep track of getting back those 75 patients for their annual exams through some resource within your office. I realize it's a lot to ask, but those are the things that some providers I've heard are doing. They basically use an Excel spreadsheet.
Unfortunately, in those cases, right? Well, thank you for that. I wish we had more time today because there's so much more that we'd all like to ask, but we have definitely recorded all of the questions that have been sent in earlier or during the webinar, and we will get responses to those. Thank you to everyone who did that. And I want to also add that there'll be a brief evaluation as the webinar has ended, and we would greatly appreciate your responses to those so that we can continue to provide needed education going forward. And a slide set as well as recording of this webinar will be available on the Dialogue for Health website in about a week. If you shared your email address with us during registration, we will be able to send a link when that becomes available. So thank you again for your participation. Please be on the lookout for the next webinar in our series, which is going to be September 30th, and ones after that. And feel free to contact us for any further questions.